No, I
cheap
haven't.
jewelry for ladies. If people are allergic to nickel or cobalt, then that'll happen. A lot of the implants have titanium in, cobalt, chrome and nickel. So those are the main things. It's not a routine test to check that, but it's a rare complication for rejection of the implant. So if there's any concern with metal allergies in the past, then we test for that.
Okay. All right, no, that makes sense.
The other thing with it being metal, obviously, if you're going through an airport,
I
many
was going to
people...
ask you that. Everybody always tells me, you know, if you
Is
have
it going to
these
set
things,
the alarms
what's
off?
it going to do? Yeah.
Yeah. Now the thing with that is it depends more on the sensitivity of their machines, and they set it differently.
All right.
So some patients get beeped, some don't, depending on the airport and the test. I've spoken to airport security when I was in France, and they said that even if we provide them a letter, they will still just feel and make sure there's no bombs attached to the customer, just because a letter can be forged. But we do supply letters for patients who are going to fly.
Okay. So I'm still going to be able to fly with this implant?
Yes, you'll be able to fly.
I'm glad to hear that. Now that answers a lot of my questions. If anything else comes up, can I ask you about that? Is that all right?
Yeah, there's just one other thing I might just mention to you as well, Bruce, is I know you had some back problems.
Yes.
Now what we do find is having a hip replacement or a knee replacement changes the way you walk. It takes away the limp and the stiffness. So when you're getting out of a chair, often when you're walking in, you use your back a lot more when it's stiff and painful in the hip and the knee. So some patients do have some relief of the associated symptoms in the other leg or in the back when their hip is improved. Doesn't mean it's going to cure the pathology, but that's one of the things that will improve your range of motion, less work and compensation through your back, and many patients have some relief on their back pain. There's other benefits as well though.
Like what?
You can get off those tons of medication, the anti-inflammatories that affect your kidneys and your bowels and your heart. There's a lot of evidence that certain anti-inflammatories affect your heart.
I've heard that. Yeah.
You'll be more active, so you'll be able to walk, cycle, your fitness levels, so your heart and your lungs. And that's what's going to determine how long you live, is how healthy you are. So those are the benefits of having a joint replacement, is you're able to improve the rest of your life as well.
Oh, that sounds really, really exciting. I think I must just go for it, Dr. De Beer. I really do. I think it sounds like the right thing for me. What's the next step?
So Bruce, I'm going to hand you over to Reshma, and she's going to take you through all the protocols for setting that up for you.
Thank you so much. I look forward to it.
No, good to see you again.
Thank you.
Bye.
To help with the perioperative information for patients. Some of the administrational information that would be helpful is that once a patient has decided to go for a hip or knee replacement, the practice will provide a consent form which highlights the type of operation that will be performed, whether it be a hip or a knee replacement, as well as the potential surgical complications that can occur. There are rarer complications which are not listed on this, and the anesthetic complications will be discussed by the anesthetic team. There is also a form for the patient pain scores, and we do this pre-operatively and then again at 6 and 12 weeks and at 6 months and 1 year, telephonically. This is to monitor the progress and the success or failure of the procedure. An authorization number is needed prior to surgery. The hospital has a pre-admission desk which contact the medical aid and arrange the authorization number and also to find out about the prosthesis limit. Blood tests that are done include a full blood count to see what the hemoglobin levels are. That will just determine if a patient can safely have an operation without a transfusion. We also do a kidney function, and if this is abnormal, then we would need to see appropriate specialists before. In certain cases where patients have other medical conditions, further blood tests might be needed. For example, if patients are diabetic, an HbA1c will be required, or if there's a suspicion of a vitamin D deficiency, that test will also be done. It is helpful to have reports if you have seen any other subspecialists recently, including a cardiologist report or renal physician or a pulmonologist if you are under the care of such a physician. We will forward this on to the anaesthetist, and they will then decide if they need to see you prior to the surgical day or rather just on the morning prior to surgery in the ward. The transfusion is fortunately quite uncommon for healthy patients who have a good hemoglobin and are going for a standard hip and knee replacement. Some more practical points An anesthetic consultation, as we mentioned, is not necessarily required for every patient, but rather for patients with uncontrolled medical conditions. Some patients are on anticoagulation before the surgery, and this might be modified, and it's important to let the practice know if you are on any form of anticoagulation, whether it be warfarin or ecotrin or any of the other newer drugs, so that this can be dealt with appropriately prior to the surgery. It is very important to actually go for a physio session prior to surgery. You'll see in the next section when the physiotherapist shows how important it is to know how to get in and out of a bed, how to negotiate stairs with crutches. And having practiced this before makes it much easier after the surgery, and also to go home, it makes the patients far more independent. Occupational therapy is helpful if you have an unfriendly home for patient on crutches with the stairs, and if you need railings in the bathroom to help get yourself up off the toilet. And they can go and visit the home before the time and help with these modifications if required. Very importantly, and often overlooked, is domestic arrangements. When a patient is going home after the surgery, it is important to have someone there to care for you. And sometimes it means having a family member come and visit for a week or two, or to arrange home nursing. And the unfortunate thing is that if this is overlooked, that patients are discharged late from the hospital. And it is known scientifically that the longer you stay in hospital, the higher the risks of medical complications, and especially surgical site infection. And a patient should not want to stay in hospital longer than necessary to prevent these complications, and therefore to make the necessary domestic arrangements prior to coming in for the surgery. What happens on the admission day? Firstly, you arrive at the hospital desk early in the morning. It's normally 5:45 for 6 o'clock. They will have the file ready, and a porter will usher the patient to the ward. The patients are seen in the ward by the anaesthetist and the surgeon prior to being prepared and received in the theatre complex. The time of the surgery will depend on a number of factors. Depends on the other patients on the list and the type of equipment that is required with the turnover of the sets. So not everyone will go into theatre at 8 o'clock in the morning, and sometimes the patients will come in to theatre complex around lunchtime or early afternoon. The reason they all come in early is so that they can see the anaesthetist and the surgeon prior to going to theatre, and if patients want to make special arrangements to come in late in the day, that can be arranged. After the surgery, which normally takes about an hour for an uncomplicated case, the patients will spend a half an hour in a recovery room while they recover from the anesthetic. After that, most patients go to the surgical ward, and it is only the patients with unstable medical conditions that will go to high care, and usually that is for one night prior to going back to the surgical ward. After the surgery, the patients are able to normally sit over the edge of the bed with a frame, and at least half of the patients are able to stand and take a few steps in the afternoon on the same day of their surgery. And this is because of the newer anesthetic and surgical techniques with a multimodal analgesia or pain control that allows this to happen. There will also be compression socks that we'll use, as well as foot massages or pumps that will prevent DVT by increasing the circulation and reducing the stasis around both legs. Ice packs are used routinely for 20-minute sessions to keep the swelling down around the operated site. We normally mobilize with a frame firstly prior to crutches, as this is more stable, and once patients are comfortable on crutches, they may or may not decide to use toilet seats. Each patient is individual, and if they can mobilize comfortably with crutches and without a toilet seat, then they do not need to take a raised toilet seat home with them. So when is the day of discharge? We have found that with the newer anesthetic and surgical techniques, that the patients normally go home after 2 nights in hospital. In other words, at 48 hours. There are some patients who are very fit and have a regular exercise program. The cyclists, the runners, the surfers that come in for surgery, some of those patients go home after 24 hours. But a patient needs to be able to get out of bed independently and be able to ambulate with a frame or crutches to the bathroom. In the case of knee replacements, we prefer to have patients able to bend their knee up to 90 degrees prior to going home. Also, patients must have no uncontrolled medical problems, and then we are able to send them home. And after discharge, at home it is important to control the swelling. Patients normally get exercise program off the internet, or we provide a booklet with all the exercises. And it's important that the first 2 weeks that you do not over-exercise. And I prefer patients to put that book away for the first 2 weeks and to control the pain and the swelling with ice and medication, so that they do not over-exercise and cause pain and swelling, which hampers the recovery process. And especially in the case of knees, will stiffen the knee if it swells excessively. Medication will be provided for home use, and that includes various forms of analgesia. And the important part is the anticoagulation. Patients don't always use their pain medication as prescribed, which is fine because of potential side effects. This is understandable. But the anticoagulation will depend on patient to patient, and this is the medication that thins the blood to reduce the risk of blood clots, and this should be taken. The weight-bearing status, or how much weight to transfer through the operated leg, will be dependent on the strength of the bone. Normally we allow 50% of weight-bearing in the first 2 weeks and graduated weight-bearing as tolerated after that. If this changes, the surgeon will let you know, and that will be particular to you if it is any different. What precautions are there? The main thing is to prevent slipping and taking chances. Do everything slower, turn slower, get in and out of a bed, and don't walk on wet surfaces, taking unnecessary risks. In the case of hip replacements, certain operations, and this will be specified to the particular patients, we need to restrict the flexion to 90 degrees and do not cross the legs. And this is for at least 6 weeks while the capsule is healing around the hip joint to prevent dislocation. As far as the wound is concerned, it's important to keep this sealed for 10 to 14 days. A watertight dressing is applied, and if this does come off, an additional dressing has been given as part of the medication to place over the wound. It's important to keep it sealed for at least the first 10 days to prevent infection from getting into the operated site. The patients normally come back to the practice for a 2-week visit, but patients from far are welcome to see their family doctor. There are no stitches to be removed in most cases, and it is very seldom that we will use the clips or external stitches. We do a 2-week visit, and this might be by the surgeon or his colleague that operates with him in theatre. And then at the 6-week visit, the surgeon needs to see the patient for an examination, and often an X-ray is required in the case of a hip replacement. With the knee replacements, the X-rays are not necessarily required at 6 weeks. The question of when to drive and when to work. Driving was traditionally thought to be safe around the 6-week mark, and normally the physiotherapist will inform the patient when they are safe to get behind the steering wheel. What we have found is with the advent of the automatic car, if patients have had their left hip or knee replaced, they can drive sooner, and often at 4 weeks because the right side is unaffected. Physiotherapy continues from week 2 to week 6, and often biokinetics will then take over. Patients who stay far and do not have access to biokinetics can then resume either Orbitrex or stationary bike or pull self-physio. What about long-term follow-up? Well, after the 2 and the 6-week follow-up, at 12 weeks, if there's problems, we see the patients. But we prefer to have an email or a phone call from them if they are doing well, so that we do not waste their time coming from far to an unnecessary 3-month clinic. It is preferable to have at least an X-ray follow-up at 1 year and then every 5 years thereafter to ensure that there is no problems with the bone prosthesis interface. Our next presentation will be on the physiotherapy in hospital.
Morning, Mr. Webb.
Morning.
Time to get out of bed. Are you ready?
I hope so.
Okay, bend up this knee, and first what you're going to do is shift your bum over to the edge of the bed. Okay, so let this leg rest on the bed. Lovely. That's it, a little bit more. And now we're going to sit. So if you can scoop this leg underneath the back of your operated leg, feeling okay? Good. You're going to use your arms to push your body up, and you're going to swivel your legs over. I'm here to help you if you need me. Good. Okay. Feet down on the floor. How's that feeling?
Great, thank you.
Good. First time after anesthetic, you might start feeling a bit dizzy, so just let me know.
Okay.
Okay, so far so good. So where are we going to stand? We first use the walking frame
Cool.
because it's a lot more steady and you might need that if you get a bit dizzy. Okay.
Okay.
That goes there. What you're going to do is you're going to stand using the weight through your good leg first, and then you're going to lower the weight through your operated leg when you're standing.
Okay.
Ready?
I'm ready.
1, 2, 3. That's it. How are you feeling?
Feels great.
Good.
Yeah.
So if you lower the weight through that leg.
Very good.
Good. Any dizziness?
No, I'm fine.
Sure.
Yeah.
All right. We're going to take a walk.
Okay.
So